I think we might get started. So welcome and happy new year to everyone. It's the personality disorder and complex trauma echo. It's the first one for the year. And we've really got a fantastic program for 2023. So looking forward to it. I'm sure you are too. So my name is Demi. I'm Head of Workforce Development here at Spectrum, and my team, Liv and Eve, coordinate these sessions. Firstly, before we start, I'd like to acknowledge the traditional custodians of the land on which we meet today and pay our respects to elders past, present and emerging, and acknowledge any First Australians who may be present. We also acknowledge people with lived experience of mental ill health and recovery and the experience of those who support them, including families, carers and supporters. And now finally, I would like to welcome to our Associate Professor Sathya Rao. He will talk to us about whether we need to rename borderline personality disorder. Sathya is the Executive Clinical Director at Spectrum. He also conducts research and provides treatment for personality disorder and complex trauma. Last year, he was the recipient of the Medal of Order of Australia for his recognition of his 22 years of service in the field of personality disorder. So welcome, Sathya. And so the podium is all yours now.
Thanks. So I was asked to present briefly about this dilemma, whether we should rename a borderline personality disorder. So first of all, I completely agree that we should rename borderline personality disorder because I think it's a hopeless name, a terrible name. And so it is certainly not the right name. So we should replace it at some stage. Why it's not the right name? Both in the clinical community and in the general community, often the name personality disorder or borderline personality disorder tends to evoke a feeling in people that it is something to do with bad behavior. And there is clinicians, the community, sometimes family and friends associate borderline personality disorder with a behavioral problem, and often it is misunderstood that it is people indulge in certain behaviors deliberately, and they tend to believe that although people have a sense of control over their impulses and emotions, they're not exerting that control adequately, and they do this in a manipulative manner. So these are all misunderstandings, obviously. But that misunderstanding also perhaps informs our legal frameworks, which are not caught up with the developments of science in borderline personality disorder. So when it comes to criminal justice or civil justice or in family court systems, often people with borderline personality disorder are disadvantaged. In my belief is that to start off, it is the name itself which tends to create that sort of a misunderstanding in people. Obviously, the stigma is quite significant with the name. And see, we have been trying to explain to people saying that the personality is you, because all of us have a personality. But when it comes to your personality disorder, so that is something that one can develop because of certain factors, which is true, which is scientifically that's true, but it has been extremely difficult to sell it and communicate it to everyone, to our own peer clinicians, and certainly to families and carers and to the communities, and most importantly to patients and the politicians and the funding bodies. So if you look at the recommendations of the Royal Commission into Mental Health in Victoria, there has not been a single recommendation about personality disorder or borderline personality disorder, although all of the clinicians who have been in mental health, especially in public mental health, would know personality disorders and borderline personality disorder and complex trauma problems are the most important problems in public mental health. Also, if you really look at the hardcore science, is BPD, borderline personality disorder, a personality disorder at all? Because traditionally we describe personality disorder as something which is maladaptive, inflexible pattern of thinking, feeling and behaving that is outside of the individual's background and culture, and starts off during very earlier on during adolescence and keeps going on and endures throughout life. But that's not true for borderline personality disorder. We know that borderline personality disorder is not something which endures forever. It can be treated. It generally starts in adolescence, but it can start in adulthood and late manifestations. Even in old age, borderline personality disorder can manifest for the first time. So a lot of the definitions uh, of the very personality disorder can be questioned as to whether it is applicable for borderline personality disorder or not. And borderline personality disorder is unlike any other mental illness. And also, it is very unlike any other personality disorder. So, the label personality disorder generally is slightly difficult to fit to the concept of personality disorders, borderline personality disorder. So, we know a lot more about the biology of borderline personality disorder. We know that there is a strong genetic component. About say 50 to 60% of the reason why people develop borderline personality disorder is because of the genetics, which is dormant when in the wrong sort of circumstances, childhood invalidation or trauma, then it gets expressed as borderline personality disorder. We know that the amygdala is abnormal, and another part of the brain called the insula is abnormal in borderline personality disorder. So it's a different disorder compared to even other personality disorders. Now, what are the other possible names that can be proposed? ICD-11 has done away with different types of personality disorders. It just calls, you can only make a diagnosis of personality disorder. And for borderline personality disorder, there is a particular subcategory called the borderline pattern. So in ICD-11, you'll have to give a diagnosis of borderline personality disorder, borderline pattern. But for other personality disorders, you call it as traits. So again, ICD-11 recognizes that borderline personality disorder is not the right fit in some ways, even for the other personality disorders. In previous ICD-10, in the name emotionally unstable personality disorder was proposed. That did not stand the test of time. Complex trauma disorder has been proposed. It's not an official classification, it's the official name, but people have proposed it. Again, it's not completely doesn't fit in. Complex PTSD is a new diagnosis that has been proposed. Some people wrongly think that BPD and complex PTSD are the same. Again, not true. Other scientists have suggested the name interpersonal disorder. My own suggestion would be to call it after a scientist, call it as a Linehan syndrome or a Gunderson syndrome, and forget about the other controversies so we can get on with the treatment. The big controversy is BPD a trauma disorder? Trauma is very common. However, a third of the people don't report history of trauma. And many people who have experienced childhood trauma do not go on to develop borderline personality disorder. So if you look at PTSD, which is a classic trauma disorder, and complex PTSD and borderline personality disorder, they are three different disorders. They're not one and the same. Although there are overlaps, there's overlap between complex PTSD and PTSD because to make a diagnosis of complex PTSD, you should have PTSD in the first place. And BPD and complex PTSD shares the three criteria, which is the mood instability criteria, identity instability criteria, and the interpersonal instability criteria. But they're not one and the same disorders. So complex PTSD can co-occur with 50% of the women who are diagnosed with borderline personality disorder. BPD can coexist with about 8% of those diagnosed with complex PTSD. And the prevalence of PTSD in BPD is 30 to 60%, and prevalence of BPD in PTSD is about 35%. As you can see, there's a lot of overlap between these disorders. So BPD is not a trauma disorder. Trauma is very common in BPD and a significant risk factor for developing BPD. And if anyone is going to work with people with the borderline personality disorder, they must do trauma treatments. But if you look at the science of BPD and trauma is there is a correlation but not a causation. So it is unscientific to call BPD as a trauma disorder or a complex trauma disorder or a complex PTSD. In summary, we should rename BPD, but the science of personality disorders have not developed to the extent that we can make a conclusive name change. Trauma is a risk factor, not causative for borderline personality disorder, but trauma is absolutely an important consideration in treatment. So the debate about the name, it's gone to the extent that it is now confusing the funding bodies and the politicians, and it splits advocacy, which was very well evident in the fact that the Royal Commission did not make any recommendations for personality disorders, but they recommended trauma treatments as being the core of mental health treatment. So people currently, and also the additional problem is that people currently diagnosed with BPD and have accessed care for a diagnosis of BPD feel cheated when the name is changed to something like complex PTSD or complex trauma disorder. Our own experience at Spectrum, more than 90% of the people who access Spectrum treatments have histories of complex traumatization, developmental trauma. Nearly 2/3 of them may qualify for complex PTSD in addition to borderline personality disorder. But about 85% of our patients who access Spectrum treatments go into remission by about 18 months of therapy. Doesn't matter what therapy we do, whether it is dialectical behavior therapy, mentalization-based treatment, or common factors treatment, all of them achieve similar sort of results for not just BPD, but also complex PTSD patient cohorts. So I'll stop there. Thank you.